New variants are popping up all the time, but the one we're most worried about that's wreaking the havoc at the moment is the Delta variant of coronavirus. It's driving Gauteng's third wave. Other provinces are bracing for this highly transmissible mutation as well. Let's discuss this variant now with Professor Salim Abdool Karim, head of Caprisa, the Centre for the AIDS Programme of Research in South Africa, also member of the WHO Science Panel. Prof, thank you so much for joining us. So let's just clear out Eta, which is the variant from Nigeria. Is this much cause for concern? Is it more transmissible than any of the others? Is it something we should be worrying about right now?
Good evening, Sally, and good evening to all of the viewers. So the World Health Organization has categorized variants into three groups. The first is what is called variants of concern, and there are 4 variants of concern: alpha, beta, gamma, and delta. Then there are variants of interest, and then there are 7: epsilon, eta, and theta, and so on. So they've all got Greek alphabet names now. We kept complaining that they were hard to call with these numbers, so now we've got Greek alphabets. Eta is what we previously would have called the B1525. It's a variant we've known about for a long time. Well, not a long time, since March or so. And it's a variant that has the 484 mutation. So it has some of the abilities to spread faster and a bit of impact on immunity. But it's not one that seems to have taken root and spread in any significant way. And certainly when we look at the Delta variant right now, which is so much faster, variants like Eta have little chance in competing against it.
All right, so let's then focus on Delta. And I just want to note, before we start chatting, we have got the new infection numbers in for the 28th of June. 12,222 new infections across South Africa, 8,408 of those in Gauteng. And then sadly another 138 deaths. So the number's a little bit down. Sometimes it is that way over the weekend. Who knows where it's all going. But Delta, first found in India, we know it's more transmissible than our beta. Are you able to quantify exactly how much more transmissible?
Yes, Sally. So there are 3 studies at least that I'm aware of that help quantify this. So let's just start with, what is the Delta variant? The Delta variant was first described, I think the first report I saw was on the 25th of March. So we've known about this variant for about 2 months only. And in its first description, the Indian government released a statement saying that they discovered a double mutant. And it's a weird name to call the virus, but what they were referring to was that this new variant had 2 mutations in the receptor binding domain. So it's that part of the spike protein that attaches to the human cell. So they called it that. We didn't really fully appreciate what this variant could do until we started seeing what was happening in India. And so that's when it became clear that the Delta variant had the ability to transmit more rapidly. Now, it's not clear why it's able to do that, but from looking at the mutations, there is one particular mutation at position 681, and that mutation is right at the point where furin, which is an enzyme on the human cell, cleaves the spike protein and enables the virus to enter the cell. So it's thought that that might be the main reason why this virus is so much faster in the way in which it transmits. It's so much easier to cause infection. Now, how much faster? The estimates from the UK put it at between 40 and about 60%. When we look at the estimates from Eurosurveillance, it suggests that the Delta variant can spread up to about twice as fast as the Beta variant. So that's a lot faster. And certainly when we look at the Beta variant, which we know spreads really fast, it quickly overtook all the others. It's a snail compared to Delta, which is just tearing across and exploding and spreading so fast that it's out it's outmaneuvering and reducing the beta variant to only a small number of infections.
So one of the things we were told is in trying to establish, and we know it's not a perfect science, in trying to establish what a risk would be, that direct contact riskiness would be a 15-minute face-to-face conversation with someone if you're not wearing masks, and then you find out that that other person is COVID positive, you definitely put yourself at risk. What would the number of minutes be with Delta, do you think?
Oh, I have no idea. It would be pure conjecture on my part. But I do worry that because of its higher transmissibility and because of that mutation I described, I think it would have a lower threshold in all likelihood, a lower threshold, what we call, in science we call it an infectious dose. So you won't get infected if you just get exposed to a little bit of the virus. It's not sufficient. It's not above the infectious dose that you need. With the variants, now as we are going along, one of the likely scenarios is that the infectious dose is now smaller. And because it's smaller, individuals who might be even at a little bit more distance and who might have been exposed for a shorter time would be at risk. And we've certainly seen that. For example, in two outbreaks, the two clusters that I've been looking at here in KwaZulu-Natal, both of them were in restaurants. These were individuals who went to a restaurant in a group. First was about 7 people and the other was 8 people. And one person in that group found out a few days later that they were infected. Everyone at those tables became infected. Everyone. That's, I mean, I've not seen that in all the old studies that we looked at with the original variants. You know, occasionally 1 or 2 would get infected.
Yeah.
But entire tables, that's concerning.
And that actually makes sense. We've heard of entire families. And you know, for a few weeks before we got the official confirmation, people were saying, but entire families are now getting it. It wasn't like that the first and the second time round. Is Delta getting stronger? And I ask you because we've now got Delta Plus. Is every mutation likely going to be a sign of its ability to move quicker and infect us faster? And is Delta Plus like Delta on steroids?
You are, capturing it very well, Sally. So when we look at every new variant, so there are many new variants being created. Most of them won't see the light of day because they don't confer any significant advantage. We call it gain of function. If a mutation doesn't lead to a gain in function, then that mutant or that variant will just die, a natural death. It will just disappear. But those variants, where there's a gain in function, where it's able to do something different and new, then those variants will survive and they will thrive. And we see how Delta, with its ability to spread so much faster, is able to dominate the whole world. I mean, it's now spreading everywhere. So you've got a situation where this kind of advantage is enormous for the virus. But then the virus now develops another mutation. Delta Plus is the Delta virus together with one new mutation. That mutation is at position 417. That mutation is present in the beta variant. And we know that the mutation at 417 confers escape to immunity. So this virus is getting even better in gaining function and the ability to cause infection.
I mean, that's extremely worrying because Delta Plus, then that suggests surely that if Delta Plus starts spreading, that is going to evade quite a lot of the current vaccines. And the one ray of sunshine in all of this is that so far our vaccines are providing a fair measure of immunity and a strong measure of protection from death.
Yeah, I think one has to be careful. We've only known about Delta Plus for about 2 weeks. So, we don't really yet know whether Delta Plus is able to escape vaccine immunity. We do know from our studies, in fact, those studies that I'm quoting were done by Penny Moore at the NICD, where she took a pseudovirus and mutated it just at position 417 and showed it could escape natural antibodies to quite a significant extent. So I'm just extrapolating from laboratory data. We need to assess in clinical settings what the impact of Delta Plus will be on immunity. My guess is that at this stage we have seen with Delta something that's quite reassuring, that it doesn't seem to be escaping vaccine immunity to any significant extent. There is some measure of diminished neutralization, but nothing that we're particularly concerned about. And so if that's the case, and there's still many more vaccines it needs to be tested against, but those that it has been tested against looks like it's quite reasonable. So Delta Plus, we'll have to see whether it confers that advantage to Delta. And I wouldn't want to speculate on that at this point, just to say that that's something we'll have to watch out for.
Yeah, and I suppose it makes the point that we need to get the vaccinations going, because that helps slow down these massive mutations that we are seeing. I have to ask for a final comment from you. We know that Gauteng is in real trouble, and we need more beds. Which other provinces are you quite concerned about? Because I think it's so easy to just focus on one province and think that the rest of the country might have an easier time. Which provinces are you flagging for us this evening?
Well, perhaps I'll just make one quick point about Gauteng. I mean, the number of cases that Gauteng is seeing now as a 7-day moving average is almost twice the number it saw at peak in the first and second waves. So in other words, this is so much worse than anything they've experienced before. So you add that problem to that they're going into this battle with one arm tied behind their backs because one of their two big hospitals is out of commission, and then you add to that they don't have Nazareth as a field hospital to take the not so serious. So you got a coalition of three serious problems all coming at once, and one could not even our worst predictions would not have said that Gauteng is going to get twice as many infections as they had in the previous two waves. So what are we likely to see in the other provinces? I think because we're seeing a new variant, and because we know this Delta variant can escape natural immunity from the second wave. In other words, if you were infected with the Beta variant in our second wave, you're still at risk in the third wave. I think we're going to see quite significant increased peaks in the Western Cape, Eastern Cape, and KwaZulu-Natal. Those are the three most populous provinces. I am most concerned about KwaZulu-Natal because of its high density in the city center, and that we don't have a field hospital here. It will mean that the existing hospital infrastructure will have to deal with the load. And because of the high transmissibility, the patients come fast and furious, and they come all at once. And so the enormous burden needs to be catered for.
Absolutely, such an important message, and thank you so much for taking the time to explain so clearly what these variants mean and how they actually do mutate. Thank you so much, Professor Salim Abdool Karim, head of Caprisa and a member of the WHO Science Panel. So hospitals aren't experiencing oxygen shortages, but this isn't necessarily a good sign.